you want, we can go further with the discussion. I will have a short presentation on a single case of a very bony augment offset, but the movie about is not available for that. So I mean that we can start with the questions to the speaker. Any question from the, yeah.
Thank you very much, Dr. Perez, for the teaching.
Yeah.
So you told us that you do an extended delta pectoral with a pec major takedown. Your glenoid exposure was absolutely excellent. You got direct control for putting the screws in. I find sometimes that's not the case. If it's a muscular patient, then the assistant has a difficult time with the posterior retractor.
Case, yeah.
So, is there any other tips and tricks you could offer for glenoid exposure?
You have to do soft tissue releases, and in most of the cases, due to the you have to do the release mainly from the humerus, and you have to release all the so-called senton line of the hip around the around the inner part of the humerus, in order to push it back. The second one is you have to remove the long head of biceps, which sometimes keeping the head in front. And releases of the back of the glenoid, which is not easy, depending on the case. If the case is a simple rotator cuff arthropathy, you don't have a problem usually. However, if there are other cases where there is a part of the cuff intact, and you don't want to disrupt the cuff, it's difficult to push it back without cutting part of the cuff. And it's easy in most of the cases with where you put as an indication for the reverse massive rotator cuff tear without arthropathy. In this case, much easier. The head is going easy on the back. The best cases are the fractures. You have always a very good view of the glenoid.
Thank you.
Some other question? So about, yeah, offer. Yeah.
If you use the anterosuperior approach, you get much easier access to the back. And the anterosuperior approach, you can get better access to the back. That's another trick, if you want.
Yeah, I use in the first about 200 cases, I was using the superior approach. The problem there is the glenoid. You're not sure about the position of the glenoid, and it's very difficult to go under the lower part of the glenoid to remove the osteophyte from the lower part of the glenoid and the lower part of the humerus.
Yeah, it's demanding, but there are tricks for that as well.
Yeah.
And actually, what I do usually, I ask my assistant, and I put what we call the Playboy bunny underneath, and with the Playboy bunny, I move the assistant either to the front or to the back. It gives you about 2 or 3 more millimeters to go underneath. It's you've got a window, you have to play through the window, but that's another trick to do it. Yeah.
In this case, things were a little bit easy because there was no deformity of the bone erosion of the glenoid. In cases that you have erosion of the glenoid, I think that the PSI devices are very helpful on that.
And since we are talking about tricks, when you approach the superior approach, Mackenzie approach, what you...
Nevisor Mackenzie.
Oh, the Nevisor. Yeah, yeah, so, yeah. Okay.
My fault.
Yeah. any trick to maintain to keep back the deltoid that is muscular for the audience, just to give to get the sutures holding in a stronger.
Another thing that you can do, but I don't suggest doing that, is to release the distal part of the deltoid. But I don't advocate that. But if you're desperate, you can do that to have a better view of the glenoid.
Yes, that in the deltopectoral approach. But since we are talking about, Offer told us that he sometimes uses.
Well, first of all, I mean, just to all, everyone that have difficulties with the anterosuperior approach, with the Neviser-McKenzie approach, and people say, "Oh, you go through the deltoid, you affect the deltoid." Well, you don't, because again, I'll ask everyone here, what do you think it's more dangerous, to use a sharp scalpel or a blunt scalpel?
Blunt.
A blunt is more dangerous because you don't know where you cut. Yeah. Here, we know exactly where we take the deltoid. We take it with the osteoperosteal flap from the acromion. We don't touch it.
Okay.
And then we suture it back through the bone. And I do a technique that I call it like a double row repair, because I go through the bone and as a medial row, like a medial row, and a second row over the top. And it's so strong that we can start physiotherapy the next day. Yeah.
Okay.
I do the same thing when I do an arterial approach.
Yeah.
And I exactly remove the arterial part of the deltoid, put it back on the bone with multiple sutures. This usually work. On the other hand, you very often see that there is a gap between the fibers of the deltoid going down. The healing is not very good. So definitely there is a problem by splitting the deltoid. Do you have any?
We haven't seen it.
You haven't?
And we've been, done thousands of
Manos, what do you think?
resurfacing.
Yeah. Yeah.
Dr. Ferus is that we had some problems with anterosuperior, maybe our techniques, because we know from biology when you cut the muscle, it doesn't matter if it's deltoid or quadriceps. Yes.
I had an aspect during my presentation yesterday.
Yeah.
When you split, there is an interval between the anterior and the middle, and you split. And then when you put a suture on the muscle, I always believe that when you want to repair.
Yeah, that's right. That's right. That's what I mean.
But you have to close, otherwise you have some gap there. Even if you repair on the acromion, you have some sutures there. So we like to prep.
Okay, but there are several tricks that any surgeon has to go sharp or to take some AC joint capsule and inside. Yeah, many tricks that can.
Okay, but everybody knows deltoid. It's so important.
Yeah.
If you do a reverse, if you do a cuff repair, if anything, if you don't have deltoid, everything is disaster. So my comments about subscapularis.
Yeah.
Let's go for one step later. That you release subscapularis in all equatorium. I mean superior, inferior, as you saw it before. And my comment is with the subscapularis, we know from the literature that maybe it's not significantly important if you repair or not subscapularis.
It is important.
Sometimes they say, like the French team, that it's not. But we like to do that, but you have to be very careful, because the problem is not only hornblower sign, as Dr. Ferus said, it's also external rotation on this side. So when you have a scarred subscapularis and you're going to repair, you have to be sure that it's mobile. You have to repair in this position, in a little bit external rotation, and you should be mobile and maybe give some good.
Yes, I was expecting a discussion about the subscapularis. There is no doubt that the repairing of the subscapularis significantly reduced the dislocation rate. This is correct. On the other hand, reverse is not like the anatomic prosthesis. You don't need the subscapularis. On the other hand, if you don't repair it, at least you can avoid iatrogenic problems coming from coming from external rotation, either at the side or on adduction. It's, if you have any doubts regarding the stability of the joint, you have to put it back. On the other hand, if you leave it, you probably have a better external rotation, and you have already a problem with the external rotation. If you put the subscapularis in front, you might make it worse.
I disagree.
Okay, that's why you're here.
I disagree because I think that whatever shoulder replacement we do, a shoulder replacement is a soft tissue operation. Whether we have an anatomic shoulder there or a reverse shoulder there, the soft tissue, it will make or break its work. It's correct that the reverse shoulder does not rely on the rotator cuff, on the supraspinatus and all that. But if you have the forescapula of the subscap and the teres, you will have you make sure the patient will have good rotation. As you could see it in my presentation. I think it's very important.
External rotation.
Wait, external and internal, because if you don't put the subscap, they will have difficulties to do things behind the back, and they need it to take care of themselves. So I think you have to do every effort to balance the front and the back. That's my opinion. Maybe I'm wrong, but that's my opinion.
I agree with you. It's correct thought. On the other hand, you have internal rotators. Yeah. The problem, you have internal rotation, pec major, internal rotator. The problem of the reverse is the external rotation.
Yeah, but that's a mechanical problem with most of the reverse shoulders, that you get impingement on the base of the glenoid. That's why you see the notching. It's the same problem, and especially with the 155 degrees. Now with all the ones that moved on to 145 and 135, it's maybe less. But that's the problem. It's the mechanical problem. So you have to first have or impingement-free range of movement, and then you depend on the soft tissues to have the good
I agree on that. Yeah.
The truth is not just in one point. So we have several opinions. So as in the valgus implant as the original, there is a good external rotation in ER1, but as we go to abduct the arm, this can decrease and go to impinge. Vice versa is
impingement at the bottom on the glenoid.
On the glenoid, yes, the notching, but for the rotation, that is at the back or the front, so of the humeral component. And the 30 degrees, the 135 degrees or so, a more anatomical, has less risk for in abduction. But for me is if you have a very weak external rotation, and we consider the two options. One is go for the latissimus dorsi transfer, or to have a large glenosphere to keep the remaining teres minor under tension. Probably this is the case where a subscapularis suture can act against the external rotation.
Can be avoided.
And but obviously, if you can, if the unit is not too tight because you did not distalize too much the humors, and you can keep back without tension, you can do that. But so many scenarios that can get different opinion leaders have the true. they all. Okay. Thank you.
Thank you.
Any other? So. Yeah.
I have a question of Robert.
Yeah.
Robert, will you do in this case a stemness or a short stem? Because we saw very poor quality of the bone, and my question is, where is the limit of the compression of the bone? Because with the technique of the compression, we can achieve some stability.
I have a problem with the X-ray that that Enrico showed, with so much metal in the stem, in the shaft.
Yeah.
If this fails, God forbid, we can't take it out. I can't take it out. I have no limitations as long as I have the metaphysis cortex. I can impact bone and I can put in, and I never had a problem with that. Never. Because you can use a smaller, we have 4 sizes, so you can use the smaller size of it's the same shape, but the fins, the difference is only the fins. The top is exactly the same, the fins are different. So you can select a smaller fin and put it even in a smaller piece of bone. Yeah, the other thing is about the glenoid. Again, I think that again I have an advantage with the tapered screw, because what I would have done is I used the head of that I resect, and because this fits exactly into the glenoid, and I put it through, and then you have a compression of the graft with a screw into the native glenoid. Doesn't matter. You have a cortex there, and because it's the fixation of the screw is bicortical, you got a good fixation. It's really compressive.
Even in yeah.
Even in that, yeah.
Okay.
Andreas here, they looked at all our cases of severe deficiency of the glenoid with a verso. And we presented in second? Yeah, presented in second.
Okay.
And it works really well. It gives you the option. That's the thing. It gives you the option.
Let me say you offer. I mean that in this case, possibly your implant, not. I don't talk about the glenoid one, but the humeral side has an option, because the other implants, there's any other that has fins that need some strong bone, maybe in crisis when the bone is so soft, they don't have a grip enough. If you put a finger after the resection, after the humeral head cut, and the finger pressing the finger, you are down. So I move to a stem.
I agree. But
Yeah.
with a verso, you can do it. Because
Okay,
you cut the bone,
okay.
you put it, it's only cancellous.
Okay, I buy it.
But why we don't put, for example, cement in this case? And if we have, for example, a revision, we just put a smaller stem. We usually do like that. So we put a stem, cemented stem, and then if there's a revision, remove the stem, into the hole that remains, you just put a smaller stem with cement again.
Yes, the problem in this is not the humors. The problem is the huge glenoid.
The problem will be the glenoid.
Yeah, it will be the humors. But now you have to go away.
Yes, please.
Yeah.
Have you ever had to use anabolic treatment for soft bone?
Yeah,
Have you ever
anabolic-
had to use teriparatide in such cases in very osteoporotic patients, maybe in the first revision or so?
No, I didn't. Probably there is a field for that, but I never did.
So you just rely on the technique and you impact bone whenever you have a case where you need a stronger grip. So
No, I didn't. Now my option is when the bone is too soft, I go with a stem. Any stem, short stem is enough.
Cementless?
Cementless. My rule is cementless. And if impact grafting has worked in every situation and can be either in that.
thank you.
Could I ask you, in this case that you put the glenoid component with the graft, what's your post-operative regime was?
So until the graft would heal, I tend to keep the patient very calm. That means he can do some by the elbow, but there's a mini sling.
And how many weeks was that?
5
5 weeks.
5 weeks. Yeah.
So do you believe that in 5 or 6 weeks the graft will incorporate?
No, but there is a huge tissue at the periphery that can help.
Have you ever used two-stage graph reconstruction of the glenoid?
Yes, I had, but very, very seldom.
And what's your experience?
Since I mean that you have some resorption, and sometimes you do 2 surgeries, and you mean if I would have just done one, it would be better. Because you have adhesions, you have a sort of added troubles at the second surgery, because probably the one that you did was not the first, it was a revision surgery of other surgeries.
Any other question? Thank you very much. Thank you.
Thank you.